Aloha, I'm Mark Alexander, Executive Director of the Hawaii Medical Association. Thank you all for joining us for this evening's Conversations at HMA, a program which features discussions with physicians and other thought leaders in the healthcare arena. This evening, our topic is very timely: changing national standards for breast cancer screening. How can Hawaii reduce breast cancer mortality in our population? Our format for tonight will be the following. We'll begin with remarks and presentations by our guests for up to approximately 30 minutes. Questions, comments, suggestions, ideas via the Q&A function on Zoom is how we invite our participants to interact and to engage. Please type in your questions, comments, suggestions, ideas throughout, and we will feature as many as possible after the opening presentations have been made. For those who are in the room, we ask you to jot comments down on index cards and hand them to Mark, who will enter them into the Q&A function. Those here on site will have the opportunity to continue our conversation over refreshments after the formal program. We will end the formal program at 6:30 p.m. We want to hear from you, so please email info@hawaiimedicalassociation.org or contact us via our website, hawaiimedicalassociation.org. It is now my pleasure to introduce our very distinguished panel this evening. Our organizing and lead panelist is Dr. Scott Grosskreutz, a diagnostic radiologist with Hawaii Radiologic Associates. Joining him are Professor Barbara Hernandez, professor of the University of Hawaii Cancer Center, Dr. Ann Ignacio, an interventional radiologist, president-elect of HMA, and Dr. Laeton Pang is here in the room. He is a radiation oncologist and also president of the Hawaii Radiological Society. I welcome all of you. I thank our great panelists that are here. And now, Dr. Grosskreutz, please take it away.
Well, thank you, Mark, very much for the introductions. And I want to say how pleased and gratified we are that our colleagues at the University of Hawaii Cancer Research Center can join us this evening. There are several that are with us, and Dr. Barbara Hernandez, who has participated in several of our webinars before at the American College of Radiology, talking about the unique aspects of breast cancer and how it presents in our population in Hawaii, is here to start off our program. Welcome, Brenda.
Thank you very much. Okay, I am going to be sharing my screen, and so hopefully you'll be able to see my slides in a minute. Okay. Aloha, everyone. So my goal today is to just give you an overview of breast cancer in Hawaii, including some data that we've have from the Hawaii Tumor Registry showing trends in breast cancer incidence and mortality over the last several decades, as well as more recent data. So just to give you a summary of a snapshot of breast cancer in Hawaii, each year, approximately 1,200 Hawaii residents are diagnosed with invasive breast cancer, and approximately 300 additional women are diagnosed with in situ or non-invasive breast cancers. Breast cancer remains the second leading cause of cancer death among Hawaii women, with approximately 155 breast cancer deaths each year. Overall, when we compare ourselves to the US as a whole, Hawaii does have a higher incidence of breast cancer, and we have seen this historically. However, we do have a lower mortality rate compared to the US overall. We have seen an increasing incidence in the incidence of breast cancer here in this state, with an average annual percent increase of 2%. So this shows the long-term trends in breast cancer incidence, and that's shown in the pink line, as well as mortality rates shown in the blue line. So as you can see, the incidence of breast cancer has really increased over the last several decades, with the most dramatic increase occurring over the most recent past 2 decades. And in contrast, mortality rates have remained relatively stable and decreasing in the last several decades. And this really does reflect the similar trends that we're seeing overall in the United States. When you look at incidence in our state over this time period by age group, however, you do see different trends with the oldest age groups, that is 60 and over. Most of the increase have been seen in those age groups. In contrast, younger age groups have either remained relatively stable or decreased slightly. Now, when we compare trends by stage, we see that in situ breast cancers, or the earliest non-invasive forms of breast cancer, as well as more advanced breast cancer rates, have remained relatively stable over the last several decades. And in contrast, the localized stage breast cancers have increased in incidence. So this shows the incidence and mortality rates between 2015 and 2019 by island. And as you can see, there are some differences that we see across our counties, with the highest incidence rates shown in the blue bars in Honolulu County as well as Maui County. There are some differences in mortality, although these differences you see are not statistically significant. And so we don't believe that there is a dramatic difference in mortality across the counties. Now, getting back to comparisons nationally, when we break the comparisons by age group, we see that each age group, there is a higher incidence of breast cancer in Hawaii compared to the US overall. The difference, so you can see that 50 and over, dramatically higher incidence for women 50 and over compared to the US, as well as for those 40 to 49. The rates are higher also among women under 40. However, this difference is not statistically significant, and that may be because of the relatively small numbers in that age group. And this shows, compares the ethnic differences that we see. And we've historically seen some dramatic differences in rates of breast cancer across our diverse multi-ethnic population. And what we see here is that from 2015 to 2019, if you compare rates among younger women, that is under 50, Japanese women and Caucasian women, shown in the red bars, have the highest incidence of breast cancer for this younger age group. However, among women 50 and older, whom among overall breast cancers, are a much higher incidence than in the younger age groups, we see dramatic differences as well, with specifically Native Hawaiian women having the highest incidence rates among those 50 and older. And this shows a comparison by stage. So in the yellow bars are those in situ or non-invasive breast tumors. And you can see that Japanese women have the highest rates of these very early breast tumors. Among the localized, those with localized breast cancer, the highest rates are seen among Japanese women as well as Native Hawaiian women. And that's shown in the green bars. And for advanced breast tumors, we see the highest rates among Native Hawaiian women as well as Caucasian women. And then in the last group, which lumps everyone else that's in our smaller ethnic groups together, so in this other group. So we do see dramatic differences, in stage of breast cancer incidence. So I'll just stop there and turn to the next panelist.
Great. Our next panelist is going to be Dr. Laeton Pang, President of the Hawaii Radiological Society. He is a radiation oncologist. Laeton, could you walk us through the value of breast cancer screening and basically some of the outcomes that you might see with the population being screened for breast cancer?
Yeah, thank you, Scott. So not surprisingly, the earlier that we find a breast cancer, the more easily it is to treat it, and the survival rates are best for early stage breast cancers. It's also cheaper to treat patients with earlier stage breast cancers than it is for patients who have metastatic disease. So on that first slide is 5-year cancer-specific survival rates for stage. And as you can see, with stage 1, it's in the high 90s to 100%. For stage 2, it's in the low 90s to 99%. For stage 3, it's in the mid 60s to the 90s. And then for the next slide, looking at the SEER 5-year relative breast cancer survival rates. For localized disease, you have like 99% survival. Regional disease, if it's spread to regional lymph nodes, in the mid 80s. And for patients who have metastatic disease, it's like in the 30s. On the next slide, we have data related to costs of treatment by stage. And the average treatment cost for in situ disease is like $60,000. And this is based off of 2019 data, so I would expect it to be higher now. For stage 1 and 2, it's in the 80,000s. For stage 3, it's 129,000. And for stage 4, it's 134,000 and some change. So the more advanced breast cancers do require more treatment, combination of chemotherapy agents and more advanced therapies that we have nowadays are adding to the cost of treatment for patients with metastatic disease. So the earlier that we can detect a breast cancer, we're better able to cure them and also save costs on their treatment. So that's the basic importance of good screening. You want to have something that is cost effective, and certainly breast cancer screening has been cost effective.
Great. Dr. Ignacio, could you talk to us a bit about the recent changes in the national policies going from the U.S. Preventive Services Task Force and how they differ from the current American College of Radiology recommendations for screening for breast cancer?
Can you guys hear me okay? And see my
Yes.
slides? Okay. Thank you, Scott. I will talk just a little bit about the USPSTF, the United States Preventive Services Task Force new draft of their recommendations for breast cancer screening. And this is the draft report that's been floating out around April or May is when they released it. And the meat of the recommendations are that they recommend biennial screening mammography for women ages 40 to 74 years. And you can see that on the slide here, they've given it a grade B. And the feedback, the response from our national organizations, including American College of Radiology and other radiology physician organizations, as well as multi-collaborative physician organizations, SBI, ACOG and such, is that this new draft it's a step in the right direction. We are slowly moving towards what our physician advocates feel is the best ways to handle screening for women in this age group. The key here, one of the challenges is the biennial, the word biennial, the every other year. And the challenge is that we are very concerned about interval cancers growing. Biennial meaning every other year they get screening. And you worry about interval cancers, ones that are not found on screening, but are found later because of symptoms, usually a lump or after a normal mammogram. And in that time period, you can get, where you widen this gap of every other year, you can develop more aggressive cancers, interval cancers that have worse outcomes than those found with regular screening. So the biennial recommendation is worrisome. It's of concern. And I have a lot of patients, actually, as well as a lot of my physician colleagues will ask, why do we even care? Why don't we just go with the recommendations of our national organizations? And and just keep recommending these things whenever we feel it's clinically indicated. And that's always best practice, always to focus on our patients. But we care about the USPSTF because that's how we determine coverage of screening tests. And because of the Affordable Care Act, we rely on the USPSTF recommendations to determine the coverage of screening. So we really do want to increase screening to annual. That's consensus along a lot of groups like SBI, ACR, even the modeling of USPSTF, their own modeling studies concluded even greater benefit for annual screening versus biennial. So a lot of us are perplexed by the biennial recommendation. And I'd love to hear the commentary from our panelists on what they feel is how this is going to affect our Hawaii citizens. I also want to mention that, you know, I wanted to talk about how this applies to patients with dense breasts, because when we are advocating that women over the age of 25 get a risk assessment. That's always been a recommendation that ACR and SBI have pressed for, and we continue to press for. So, you know, we feel like the USPSTF recommendations don't really address the issues of risk or multi-risk issues in patients, particular patients with dense breasts. And I'd love to hear what other panelists think of that. But that is the meat of the recommendations, and we can go into further detail if you'd like.
Thanks, Lisa. And one of the challenges that we've noticed here in Hawaii is that women in Hawaii do tend to have an earlier onset of breast cancer because of our unique population here. From a clinical point of view, having practiced here for 30 years, you know, it was pretty obvious that we had a lot more early onset breast cancers in Hawaii than you would have with the European population and some of the US states. And that many of the women that were presenting with early onset of breast cancer were Asian. And when you took a look at studies in Asian countries like South Korea and Japan, sure enough, you know, their populations tended to have an earlier onset of breast cancer. And there's this national SEER database that Dr. Ignacio was talking about, and there was a couple different reviews of that, taking a look at the data within that for the US as a whole. And one data by Stapleton et al. Showed that the peak incidence for minority women, Hispanic, Black, and Asian, and Pacific Islanders was before age 50. A more recent review showed that had kind of broadened the curve and had moved a little bit later than life, but still as many as 28 to 30% of women, of minority women were presenting with breast cancer before age 50. So the previous US Preventive Task Force's guidelines were a real problem. We were basically, you know, it was like closing the barn door for many women after the cattle were out. I mean, they already had disease before we would start screening at age 50 as previously recommended by this task force. And this was of enough concern that the US Congress repeatedly voted to override that recommendation with what was called the PALS Act, the Preventing or Preserving Access to Life-Saving Technology Act. And Dr. Ignacio and Dr. Pang and many of us have worked on that. So anyway, it's a good thing that the task force has moved its guidelines to start screening at age 40 rather than age 50. That's a huge win. The other thing that's I think is very helpful is, you know, it's very confusing, I think, to patients when they understand that medical societies and the government, nobody can decide on what's the appropriate age, you know, to screen with mammography. You know, and now we have the US Preventive Services Task Force recommending starting screening at age 40. We have the American College of Radiology screening at age 40. We've got the American Cancer Society recommending annual mammography starting at age 45 to 54, but they encourage you know, optional screening at age 40 if women want it. Certainly, if you're in Hawaii, you know, I would encourage all women of average risk to start screening at age 40. The other thing I think that's really important is some women are at risk for earlier onset of breast cancer than other folks, and sometimes it's due to genetic conditions. And the ACR, American College of Radiology, has played a role in trying to, along with the American Society of Breast Surgeons, to try to encourage women to get screened for their risk factors for breast cancer at age 25, which makes a lot of sense. And that way, if you're at high risk for breast cancer, which is defined at greater than 20% lifetime risk, we can start screening you earlier. So some of the challenges we have in Hawaii are, one, we have women that we have to figure out a way to provide this risk cancer screening assessment. And we've been talking to our colleagues at the Cancer Research Center and Department of Health about ways that we might do that. whether that might be a web-based program, or maybe could you even use AI in the future to help facilitate that. Or if we have enough providers to do that kind of manually or with their patients individually, that's another option. Some of the other challenges that we have are that not only do Asian women tend to have an earlier onset overall breast cancer than other ethnic groups, but they tend to have denser breasts. And there was a study performed by Dr. Chris Kojima, a local radiologist over at Straub, that found of 40,000 some Asian women, 2/3 had dense breast tissue, which can make it more difficult to find breast cancers on mammography, because the breast cancers might be hidden by this naturally dense breast tissue. And that means that, especially for Hawaii, it's really important that we keep our mammography equipment up to the current standard, which is what's called tomosynthesis. So a standard mammogram for decades past has been great. It's reduced breast cancer mortality by about 42% as compared to people who had never been screened. But when you take this new technology, which is digital, and it also has, it says like tomographic slices of the breast, almost like a CT scan, you can find a lot more cancers than you might otherwise have found with conventional mammography. And so, the increase in detection rate for women, especially with dense breasts, with this tomosynthesis mammography, it's about 20%, but it also decreases false positives and decreases the recall rate as well. So anyway, that's a real boon, and I'm glad that we were able to get that introduced in Hawaii. We were one of the states that didn't have very many of those units available. In 2019, we worked together to introduce legislation, encourage the insurance industry to cover that. Some of the other challenges we have are if you do have this high risk for breast cancer of greater than 20% lifetime risk, they do recommend additional screening. And the recommendation is to have an annual mammogram starting, at the time that you're diagnosed at high risk, from say 25 to 30, as well as an annual MRI. And MRI is now becoming more commonly available to people. In the event that MRI is not available in your community, or if perhaps you've got reasons you can't get an MRI, like a pacemaker or something like that, there's other options available. You can get a mammogram these days with an IV contrast unit that's similar to what we use for CT scans. And that also shows some increased value. So contrast enhanced mammography is one tool that we'll have available, and the American College of Radiology recommends this as an alternative to MRI. The other thing that can be very helpful is something that doesn't have any radiation, that's relatively inexpensive, and that's called whole breast ultrasound. Now, it's not widely available, but we've been using it in Hilo for 30 years, and we've literally found hundreds and hundreds of cancers over time that mammography couldn't pick up because it was able to see them hidden in the dense breast tissue. And so we think that has saved a lot of lives. The other challenge that we have is that, unfortunately, we don't have enough providers in the state of Hawaii, and that includes nurses and APRNs and PAs, as well as physicians. And I was working at the Women's Imaging Center in Hilo the last 2 days, and on both days, a woman walked in with advanced palpable cancer that had been there for at least half a year and eroding through the skin. One woman was actually, unfortunately, bleeding from this erosive tumor, and they were having trouble finding a healthcare provider. So sometimes people will find a lump or a mass that normally would be picked up by the clinical examination if you went for your physical every year, or you went to see your OBGYN or your primary care person who would help guide you and encourage you to get screening with mammography. And sometimes people don't have anybody they can talk to. And so they just, one woman actually talked to 16 different physician groups at Hilo looking for someone that could take her, but didn't have any room in their practice for anybody else. So some of the ways we can manage that, one is that I think women in the state need to be aware that you can self-refer for mammography for a screening mammogram. And even if you got a palpable lump or something, if you don't have anybody else to help you get set up with screening, you can just come in for a screening mammogram and talk to the radiologist, and they can convert it to a diagnostic study and add additional tests. And we also have to find, in the situation where we have as much of a shortage of 40 to 50% physician shortage on islands like the Big Island and Maui in recent years, those providers that are going to make themselves available to take care of these women who are presenting that don't have anyone else involved in their healthcare system that have got possible signs and symptoms of breast cancer. So those are a few things, I think, a few challenges we have ahead of us. And I'd be happy to let's Professor Hernandez or Dr. Pang or anyone else step into the conversation here with your thoughts.
So historically in Hawaii, I think our rates of mammography use have been higher than the country overall. So we do know that to some extent that is driving some of the higher incidence of breast cancer. However, from the data that I showed today, you know, what you would expect that if it was entirely driven by higher screening rates, that you would see increasing rates of the earliest in situ tumors. However, what our data show is actually it's not, those tumors are not increasing in rate, it's the localized tumors. So to some extent, that does show you that, you know, there is evidence that the increase is not entirely driven by screening, higher rates of screening and increasing use of screening, and that there may be underlying risk factors and exposures that are increasing, contributing to the increasing rates.
I think too, one of the things we should talk about is, you know, overall Hawaii has got pretty good health, you know, care statistics. We're at the top of the nation in many categories, which is commendable. And some of that's due to our population, the fact that it's sunny all the time, and we're not cooped up and, you know, in winter and gaining a lot of weight, things like that, like people do from my home state of North Dakota. But we still do have significant healthcare disparities. You know, we see a significantly higher death rate from cancer in minority women, particularly Black Americans, and also for Hawaiian women. And we also see an increased rate, you know, percentage of those women coming in where they've got advanced disease and cancer that's spread to the lymph nodes, like I've just talked about. You know, and my gestalt on that is these are usually underserved populations where they don't have as much access to screening, either for their risk status or even to get screened for mammography and other tests, and they don't have a primary care provider. And that's a real concern. And so I think that's one of the challenges that we have in front of us, that we have to strive for good outcomes, but we have to strive for good outcomes for everyone in our society. The other thing,
so Scott, you raised an interesting point about disparities and how the provider shortage in Hawaii can affect diagnosis, early detection, and outcomes. It seems to me that the shortage is most acute on our neighbor islands. Can you give us an idea on the Big Island what the availability is for breast cancer screening with mammography? And are there enough providers? Are there enough units to even screen the women that are on that island? Or where do we need to go in terms of provision of these services? And how many more providers do we need to provide these services?
Yeah, that's a challenge, Dr. Pang, that we've all been looking at, from the Hawaii Radiological Society. We have shortages of radiologists as high as 50% on the neighbor islands, and of course, that's a specialty that does the breast cancer screening, and so that's a real challenge. There are, like on the Big Island, there's mammography available at North Hawaii Community Hospital. It's also available over at on the west side of the Big Island, and also we've got a spot in Hilo, and Kaiser does some of their own patients. They have a screening mammogram unit, but really there's going through these screening studies, and then there's the diagnostic aspects. If you've got something where somebody comes in with a lump or a bump or a nipple discharge, or they have axillary adenopathy, whatever, that it requires a diagnostic sort of approach to it. And there aren't enough diagnostic radiologists available. We used to have 4 of us here in Hilo. Now we're down to 2 of us. The breast cancer specialist that was hired to replace me, unfortunately decided he had to leave the island because of access of healthcare for his wife, who had some medical conditions, and also his inability, to just be able to make ends meet. So those are real challenges. we're seeing a lot more radiologists, working for mainland companies, and our group does some of that. But I mean, as the fewer people we have, fewer boots on the ground we have in Hawaii providing those services, the more challenges we will have with breast cancer detection and biopsies and things like that. And I think this is a good time to bring up a couple different points here. So there's been some success with bringing the age of screening with U.S. preventive task forces down to age 40. So that's a very good thing. There was the one study published in the Journal of Cancer that stated that half of all fatal breast cancers were diagnosed before age 50. Now, that doesn't mean that, that all those women who had the fatal cancer died at, by the time they got to 50, a lot of them lived longer because of treatment and things like that. But there's certain cancers that you tend to get earlier in life that tend to be more aggressive. The U.S. Preventive Services Task Force said, well, listen, we might be over-diagnosing too many cancers. And there's too much stress related to biopsies. Those were their big concerns. That's why they were saying, don't screen nearly as much as the American College of Radiology would recommend. And it's true if you've got somebody who's maybe 70 or 75 or 82 that's got a small low-grade cancer that they might just outlive it, that other things would, their lifespan would be over before the cancer killed them. But that almost never happens in younger women, especially with invasive cancer. One study showed that probably less than 0.1% of breast cancers in women before age 50 were overdiagnosed. The natural history of these cancers is basically to kill people, unfortunately. So I just don't buy that as a reason, not to screen at age 40. To me, it's more of an argument to screen at age 40 and screen every year, as Dr. Ignacio pointed out. Some of the issues that occur is that if you're screening every 2 years, you've got this chance of a cancer developed for it to grow for a 2-year period before it's picked up. And breast cancers in younger women tend to be more aggressive. And that's for several different reasons. If you're what they call BRCA positive, which is a type of genetic anomaly that causes a very high rate of cancer in women, those cancers tend to develop early and they tend to be aggressive. You've got we know that there's a higher rate of what's called triple negative aggressive cancers from Dr. Hernandez's research at the University of Hawaii and other researchers that tend to occur more in African-American women and in Native Hawaiians. And those also tend to grow rather rapidly. And even if you've got the run-of-the-mill cancer that's got hormone receptors, if you develop those cancers before you hit menopause, the natural hormones in a woman's body will encourage them to grow at a faster rate. So that's all the more reason for me to believe that the American College of Radiology is right, and you should screen annually with mammography beginning at age 40 for average risk women, and screening earlier in women who are deemed to be at high risk of greater than 20%.
So Dr. Grosskreutz, we have a comment and a question that came in. We're fortunate to have Professor John Shepard also from the Cancer Center online, and he sent in a comment. The reason there are different recommendations from each professional society is that they use different criteria for choosing the threshold for initiating screening. Collaboration between associations will go a long way for building public trust in recommendations.
Yeah, I think that's dead on, and so I'm glad that the recommendations are starting to get more uniform as time goes by. I think even the U.S. Preventive Task Force's own data shows that if you follow ACR guidelines, you'll save the most lives. And so if you were to follow the old or the ACR guidelines, right now we're looking at least a 42% reduction in breast cancer. And that probably doesn't include all the benefits of some of the modern technology like tomosynthesis. If you take a look at the American Cancer Society guidelines, it's significantly less, it's about 10 points less. And if you go down to starting mammography, the old U.S. Preventive Task Force's guidelines starting at age 50 and going every other year until age 74, you're down to about 23%. So you can see that, moving from about 42% to 23% is a big reduction in the number of lives you can save. It's almost half. And so I totally agree with Dr. Shepard, and they're working on a mammography program in the state of Hawaii to really tabulate the outcomes that we have in screening and to take a look at the density of breast tissues. And Dr. Shepard's a worldwide expert in that area and holds a conference every year that people from everywhere come to listen to. So, we're very lucky to have that type of expertise in Hawaii. And, you can't, you always have to be somewhat humble about this, Mark, because you can't just say, well, I've been in practice for 20 or 30 years, and this is what I know from that time, because these things change all the time. And I think the U.S. Preventive Services Task Force deserves some credit, because the Hawaii Radiological Society and patient advocates and the American College of Radiology, we all approached that organization and said, listen, we've got this concern about younger women developing breast cancer, especially in minority populations. And you know what? They looked at it, thought about it, and came back and changed their guidelines. So I think that's good. And it may be that as time goes by, the things we're recommending right now will change completely as well. I mean, if they come up with a breast cancer vaccine, or they're working on that right now for triple negative cancers, or if they come up with a genetic assessment, maybe at birth, where you figure out what type of problems you're prone to, or they come up with, like a liquid assay or a blood assay where you get a blood test and it tells you whether or not you might have cancer in your body. Those are all things that they're working on, and they may change the world completely. And who knows what, maybe in 8 or 10 years, we won't need mammography anymore. We'll have different sorts of tests that work better, and that would be fine. But that's the whole purpose of being attentive and supportive of research, so we can find new and better ways to do things.
Thank you. MJ, we just have initials here, asked, how many more physicians do we need on the neighbor islands to provide care to and to diagnose the women on the islands?
Well, I guess I can start off with that. We need a lot more than we have. So Hawaii has a shortage of, around 20% of the providers we need. We also have the second oldest physician workforce in America. So a lot of us are, kind of getting along with the tooth and close to retiring. The shortages have been found to be as high as 25% on Kauai and between 40 and 50% on the Big Island and Maui in recent years. And I mean, you always find somebody to diagnose you. The question is, are you going to see your OBGYN or your primary care APRN or whoever it is to refer you for annual mammography? And hopefully seeing, radiologists who's, can find those cancers at an early stage where they're very highly curable, as Dr. Pang mentioned, or whether you're going to be walking into a federal healthcare clinic because you don't have insurance or you don't have a provider, or you're walking into the ER with a big palpable mass. You will be diagnosed at some point. But the question is, you have the providers and the equipment available on your island, in your neighborhood, to help you be diagnosed at a stage where we can actually make a big difference and very likely cure your early stage cancer.
So part of the disparities issue, Dr. Grosskreutz, is access, but then there's also cultural attitudes and other access issues that would also need to be addressed. So there are some cultures whereby they have an inherent distrust of the medical system. How do we overcome issues like that? I
think the best way to do that is with community advocates, to be honest. You can, there are, you can go to, to the internet, or you can provide radio commercials and things like that and encourage, patients to come in. And I think that's well worth doing. Organizations like the Hawaii Department of Health, can help with that. I think, a promoting a campaign of promoting screening and educating women that they are eligible and able to refer themselves for mammography without even having a doctor. I think that could be a very helpful thing. I think some of the most helpful advocates though that I've seen myself in my career are women who have suffered from breast cancer, beat it, and then come back to be advocates to try to encourage, people in their community also to come forth. We've been working with advocates like that, like Zara Khan, who was a woman on the East Coast who had breast cancer, of Middle Eastern descent. And, her community has some of the same issues that you're talking about, Dr. Pang, a reluctance to be screened routinely. And she's working, very hard to educate women that they need to come in. I think that's something that's also really needed for, African-American women in America and for Native Hawaiians, to encourage them to come forward and also to be screened, because not uncommonly, you'll see somebody coming in, sometimes with breast cancer, even in their late 20s or early 30s, and they'll walk in, and when they sit down and you find out and you make the diagnosis, oh yeah, I was always worried about this because my auntie and my grandmother and my mother and my sister at age 26 had a cancer, and nobody knows about that. We find out about those really, family histories that are of concern only after people present with a palpable cancer, and that's not when we want to do it.
I agree with you. I think that there's a lot of opportunity out there for collaboration between patient advocate groups and professional organizations. It's just an issue of, well, many issues, but funding would be number one, organization two. But I think, somebody has to take the ball and run with it. Problem for us as physicians is we're so busy doing our clinical stuff, and there's already a shortage of radiologists. Who will take the ball and run with it? Do you have some ideas as to how we move this ball forward?
Well, some of the things are pretty simple. We really need our hospitals, here in Hawaii. They need to be well supported. Many of them are subsidized by taxpayers' dollars with the HHSC system.
Chris Neal.
Sorry about that. The other issue is, there's a lot of people in private practice, that are often working, 60, 70-hour weeks because they can't recruit anybody to take their place. Nobody else is there available to take care of their patients. A lot of these providers are working, into their 60s and 70s often, sometimes into their 80s. And as in your field as a radiation oncologist, this equipment are extremely expensive. These units can cost you $1 million or more. That's also true for MRI scans and things like that, for breast MRI or even mammography and ultrasound. These units are all hundreds of thousands of dollars. And for those that are in private practice, what they call for-profit model, this is just so simple. If you're like any business, whether you're a grocery store or a hardware store, or you're a doctor or APRN, running a medical practice, and you're working for profit with nobody to subsidize you, if you don't make a profit, you don't stay in business, and sooner or later you lose your staff and you can't keep your doors open. And that's just something we're seeing statewide. And that isn't an issue that seems to be that hasn't historically been taken seriously, I think, by Medicare and the insurance industry in Hawaii. So we'll be meeting with the chief medical officer for CMS, who's very smart, Dr. Ashby Wolf, next week, and we hope to have some good conversations there. And we also, have to, I think, help to have a dialogue with local insurance companies to point out that it just doesn't make any sense, to be reimbursing at levels that physicians and APRNs and nurses can't provide their practice in. I think a good example of that is on the island of Molokai. They had two older physicians who both recently died, worked until they're, basically died with their boots on, and they didn't have anybody taking care of the community. And Dr. Dang Akiona, who's a recent graduate of the family medicine program, who trained, in part with us over at Gila Medical Center, good for her. She's going over there and setting up a clinic, to take care of that community. And I think she deserved a tremendous amount of help with that. But she's pointing out, on her posts, on social media, that literally it's almost like a business suicide decision, because there's no way she's going to be reimbursed enough to be able to pay her costs for providing that care. This is just a choice society has to make. Do you want to go to the grocery store and have food? Do you want to go and have somebody that's, pediatrician taking care of your kids in your local community? Do you want to have an OBGYN? They're just closing the last private practice, obstetrical practice on Maui this year. There'll be no one in private practice delivering babies on the island of Maui. Think about that for a bit. So anyway, I think our leaders at the level of the governorship and the state legislature are starting to take this very seriously and have got some good ideas. And I appreciate that the HMA and our physician leadership is continuing a dialogue to see what we can do to get enough healthcare providers to take care of people in the state of Hawaii, because that's where the rubber meets the road.
So several other questions have come in. So this is a great discussion. One came in from Dr. Elizabeth Christensen. Do you have concerns about exposure to radiation from diagnostic testing as a risk factor of breast cancer?
Yeah, that's a really good question, Mark. And as we all know, radiation, especially in high doses, can cause cancers in some people. Fortunately, the dose for mammography is fairly low. It's kind of akin to what we would get from natural radiation from in the sun and background radioactive elements in the Earth crust every year. And so, especially at the age that people are starting mammography routinely at age 40, the latency period would be so long that in a very rare instance, and this would be like 1 in a million or something, that a woman would have radiation due to being screened between age 40 and 50. Her odds of survival are so much better because breast cancer is the second highest killer of women. It happens to 1 out of 8 women. And if that woman unfortunately had a breast cancer that could have been caused by a mammogram, if she keeps being screened, we'll pick it up in early stage with like a 98, 99% chance of curing it. So good question, but that's the answer to that.
My understanding is that earlier mammography techniques did have higher doses that were being used, and they did contribute to higher risk of subsequent breast cancers. But the newer techniques of mammography have much lower dose and have not been shown to increase the risk of breast cancer. And even tomosynthesis really only has twice the amount of radiation as a regular mammogram. So it's not that much higher, but yet it provides us with a lot more data.
Yeah,
and
I think I've seen
breast MRI has no radiation at all.
Yeah, I think that's a good point, Dr. Pang. And I have seen one study that took a look at women who are highly susceptible to developing breast cancer because of BRCA genes. And it showed like a small increase in breast cancer that could have been related to radiation. But as you point out, there's other tools that you have available, especially when women are in their say you determine they're high risk at age 25 to 30 or 35. Those women can still be screened with breast MRI or with ultrasound, and neither of those have any radiation at all.
Dr. Marty Weideman posted the following: how do women self-refer if they do not have insurance and or are not on Medicaid or Medicare?
What I would suggest they do is they just call their local mammography facility and just say, I would like to self-refer for care. And there could be discussions at that point about getting in to be scheduled and how that might be covered. There are funds available from different organizations, different grants and things like that for women that don't have any insurance. But I don't think any of us at practice ever want insurance to be a barrier to care, especially if you're coming in and you've got a lump or a bump or something else that's going on that you're concerned about. Don't hesitate to come in and see, and get screened, because if basically people can't pay, then they don't pay, and that's just the way it is too, and that's to be expected. There's a lot of charity care out there, but there'll always be a way to do this. So don't hesitate to come in and get screened. We'll work. Financial issues are secondary and they can be taken care of.
Thank you, Dr. Grosskreutz. Professor John Shepard added this comment: international and continental models of breast cancer risk are not very good for Hawaii because of the aggregation of Asian Americans and Native Hawaiian Pacific Islanders into the one category. As Brenda demonstrated, there is a disparate risk by ethnicity. Can the HMA make a statement for the disaggregation of ethnicity data across medical centers? And Dr. Ignacio, as chair of our Public Policy Committee.
Absolutely. So it's a great comment, Dr. Shepard. Thank you for that. Absolutely, our physician advocates recognize that there are disparities in ethnicity that apply to breast cancer screening. And we have supported, as of this recent legislative session, for example, all of those multi-ethnic cohort study, the bill that was related to UH Cancer Center. And so definitely, yes, I think that Hawaii Medical Association would definitely support that disaggregation statement, and we can talk about that offline to see how we can best work together for that. But I think it's absolutely necessary to get that information and get it spelled out that way. Yes, the answer is yes.
Yeah, it's an issue not only in medical care, but in so many areas like in housing and homelessness issues as well. Dr. Madam Joshi, I'm sorry if I'm mispronouncing your name, who's MJ, made the following comment. I recognize I'm being a pessimist. Many insurance companies are listed on the stock exchange. They're beholden to stockholders, not to us physicians nor patients. Insurance companies have no upside to providing care to patients or compensation for physicians. Any give on their part will be too little and ineffective.
Yes. No, but I think too, I mean, we're all shareholders in the community, and you know, there's a need for insurance. Most of us don't want to be paid in chickens anymore. We've got our own chickens at our farm, so I don't have to worry about that. But you know, the insurance companies, they do play a role, but there needs to be an equal dialogue, at least between insurance companies and physicians, to resolve some of these issues. Sometimes the legislature can step in and pass legislation like, you know, promoting the ability of a woman to self-refer for mammography. You know, there's so many issues out there, but one of the things I think is a real concern is you have, you know, nurses and doctors and APRNs, you know, people that have spent decades sometimes in training, decades, you know, and they know their field. And sometimes they feel like insurance companies are practicing medicine by second guessing literally every step that they take, every decision they make, you know, which greatly decreases morale among healthcare providers, wastes a lot of their time, makes them much less productive. And much of it's quite unnecessary. So I'm glad to see the American Medical Association stepping up at the national level and working at different states. There's about 30 states across the country right now that are considering prior authorization reform to get some common sense reforms. And so there's some level of insurance that national standards are being followed in terms of care, but at the same time, getting away from some of the abuses and delays in care that can be problematic. The AMA wrote the director of CMS and basically, listen, we 90% or more of the doctors that responded to a survey, you know, we're seeing bad outcomes and delays in care and denials for patients for care that was really needed. And about a third were saying that they were seeing really bad outcomes like death, hospitalization, and permanent disability from the prior authorization process. So, you know, I think it's good that movement's picking up steam. I'm sure glad we don't have to get a prior authorization for every mammogram we do, because the death rate would go through the roof. I mean, to be honest. So it's the easier we can make access to care, you know, for things like mammography by national standards, the better it is. And I don't think there should be any roadblocks between patients who need that care, healthcare providers who recommend that care or authorize that care, and getting that care done.
Well,
I
we're
also want to
fortunate
say,
that,
if you don't mind, if I could just break in and just say to Dr. Joshi, I appreciate his honesty in saying, oh, I'm a pessimist. I have plenty of physician colleagues who feel like you do. And they're also secret optimists, because we just have to stay in these conversations and not give up. I really think that although we you know, debate a lot with our carriers, we want to continue that conversation, and HMA is doing that. We're trying to continue the dialogue on a lot of these areas with HMSA, one of our primary carriers here in our state. We actually have an event hopefully coming up soon where we will open that up to our membership. But staying in these conversations, expressing and being engaged in all of these policies is important. And I'll just remind everyone that this draft of the USPSTF is still open for public comment until June 6th. And they definitely want to hear from everyone. So physicians, patient advocates, everyone, organizations should submit comments on their website. We're happy to share that information. But thank you for your comments. And Dr. Joshi, we appreciate you being engaged.
Yeah, I think it also provides opportunities for engagement with our payer organizations to address some of the disparities issues, because it is a public relations issue. And so if we can bring them into the conversation, maybe we can get some positive outcome from that. Maybe they're willing to, we'd have to discuss this with them, be willing to fund some of the things.
Well, I can let you know, and Dr. Ignacio already indicated this. Dr. Mark Mugiishi, the president of HMSA, has already agreed to have a special conversation at HMA session with just HMA members. So we're in the process of scheduling that now, probably for later in the summer. So he really wants to have that kind of conversation. And so HMA members will have that special opportunity in the very near future. Dr. Christensen made the following comment. I recommend more discussions in the future regarding prevention of cancer through lifestyle medicine, energy medicine, and stress reduction techniques, etc.
Yes, yep. Again, that's a good point. Sometimes in Western medicine, we tend to focus. We're very good on dealing with, the end stages of lifestyle problems. So we could go in and root that calcified, clogged artery, better than they can in different areas of the world. But wouldn't it be better to prevent that from developing in the first place? And so, exercise, weight control, moderation of alcohol. There's just so many different things that could be done. Healthy diet, and that's traditionally has not been given enough thrift by Western medicine, and it should be.
I wonder if we didn't offer Dr. Ignacio the opportunity to talk about the advocacy issues and priorities that might tackle for next year.
We can elaborate on those further if you like. As you guys know, we continue to hope for more expansion of coverage for breast cancer screening. We support all of those multi-ethnic cohort studies for UH Cancer Center and other policy and regulatory changes that are going to expand breast cancer screening for Hawaii citizens. There's also some national initiatives that are out there. For example, there is a new bill that's out called the Find It Early Act. As you guys know, Katie Couric, celebrity journalist, she was diagnosed with breast cancer last summer. And so I think representatives have used her clinical diagnosis as a platform to help move forward expansion of coverage for higher end additional imaging for breast cancer screening. And it's Representative Kirkpatrick and Duraro in Connecticut or something that have introduced that. So there are a lot of different initiatives that we're supporting. We're happy to hear from our members and our patient advocates as well, and support whatever we can do to help screening and help cancer survival in Hawaii. So always open to more ideas. So please reach out and let us know.
Yeah, I think that kudos have to go out to the Hawaii Radiologic Society, because this was a national issue that people have been fighting at the national level, even congressionally, almost every year with renewal of the PALS Act, for a decade or more. And so anyway, realizing that the U.S. Preventive Services Task Force guidelines did not serve our population well in Hawaii, we were able to, partner with, some great patient advocates, with national organizations like the American College of Radiology and the American Society of Breast Surgeons, and really get the story out there in the Washington Post and different medical journals. And I can't help but feel that made a difference. And so I think it just goes to show that if you work together, and especially with patients and patient advocates, that you can make a difference even on the national scene.
Well, thank you very much, Dr. Grosskreutz. It's a great comment to begin to wrap up our session. I know Professor John Shepard made a couple comments about what a great discussion we've had today. It's been great panelists and great participants. So thank you all very, very much. As we come to a close, I want to indicate a very special mahalo to everyone for joining us for this edition of Conversations at HMA. Mahalo to Dr. Scott Grosskreutz, to Professor Brenda Hernandez, Dr. Elizabeth Ignacio, and Dr. Laeton Pang in the room, and all of you for participating. We know you have your choice of evening activities, so thank you for spending some of your time with us. We thank you especially to those physicians who are members of HMA, and for those who would like to join a community committed to physicians, their patients, and community health. Please check out HawaiiMedicalAssociation.org. And you will note in the future, we'll be having a YouTube channel for HMA. And so some of these conversations at HMA will be available to the more general public. And with that, mahalo and good evening.